I'm having trouble with my computer on my end hearing you. So you're going to get like a gift today. I'm just going to kind of go through the cases. So you don't get called on or anything. I'm just going to kind of go through and show you what I'm looking at. But there's something wrong with my computer hearing you. So I would probably have to reboot it and make sure the sound card's working from my end and everything. So I don't want to mess with that. It should take too long. So I'll just go through and we'll just kind of, this is recorded also, so you guys can look at this. So I just want to make 100% sure you still can hear me, right? There's somebody put in the chat, yes, if you can hear me or not. I just want to make sure that at least I'm not speaking to a silent room. Okay, good. So I'm just going to go through these for you guys and give you some information. If you want to chat, type in what you think the diagnosis is, you're welcome to do that. So this is a punch biopsy. I'll get it to quit circling here. Okay, and I guess you can hopefully see this is from the scalp. And anytime we get a scalp biopsy, generally we do it by, vertical and horizontal. And we like to sort of take the horizontal section kind of around this area in this zone right in here. So we can kind of see the inferior part of the follicles and some of the hair bulbs. And then we can also get a chance to see what's going on both vertically and horizontally. So at low magnification, you can see that there's a decrease in the number of hair follicles rooted in the subcutaneous fat. Normally on a vertical section like this, you should see about 8 to 10. And here we see 1. So you know this person's got an alopecia, and it's a significant alopecia. This isn't just like somebody that's kind of gradually losing their hair. This is somebody that's going to have a shiny white area there. And so when you're looking at alopecias, obviously, then you want to ask yourself whether it's inflammatory, permanent, non-inflammatory, possibly permanent or non-permanent. And, hopefully we can reverse a lot of the non-permanent, the long-standing non-inflammatory alopecias like androgenetic now. But, and then you want to ask yourself whether there's any scarring or not, where the scar is located just at the sites of the follicle. And if it's at the side of the follicle, it's around the infundibulum of the follicle. Does it destroy the follicle? Is it between the follicles? So those are all things that you look for in alopecia. So we know that this is a significant alopecia. Let's see if it's inflammatory or not. And we don't really see much inflammation here in this section. We do see a follicle that has got this markedly thickened glassy basal membrane zone here. So this is probably an early catagen follicle. It's in anagen here and it's shifting into catagen. So that means it's a dynamic alopecia. And we can get a lot more information when we look at this side of the specimen. This is a nice thing about when you look at the cross section, because you can see about, usually up to 30 hair follicles in a specimen. And notice that virtually all of these have been shifted from catagen into telogen at the same time. And so when you see that, that's virtually pathognomonic of alopecia areata. Virtually nothing else will do that. And you don't really need to see the inflammation anymore. So, the textbooks all talk about that. You got to have a swarm of bees and all that kind of stuff. And it's great if you see that, but that's really only early. If you get a lesion that's a little later and there's not much inflammation left, you're not going to see those swarm of bees, and occasionally maybe get some eosinophils. So you can't use that as a defining criterion, or you'll miss the diagnosis. And so when you see it like this, where it's all kind of shifted into telogen, at the same time, everything is shifted. Even in telogen effluvium, it's not a complete total shift. It's probably about 60 to 75% of the follicle shifted there. So when you see it like this, even if you don't see the inflammation, you can make the diagnosis of AA. And this is a nice example. You can see these little melanocytes here are kind of degenerating, and this is all due to the follicles that are turning into this residuum. They're turning into fibrous stelae. And if you look back over here at the other section, you may be able to see some of those little residual sort of wispy. This is what a fibrous stela looks like. There's not any left over here that we can see, but you just get these little wispy strands of collagen, which are sort of at the sites where the follicles used to be. That's what you see if you get a very late stage lesion of AA. There you may not even see very many follicles, just miniaturized follicles and no inflammation and just only the fibrous stelae. So that's kind of a diagnosis sort of made by exclusion if you get a really late stage lesion. Now I wanted to show you in contrast to something that comes up in the differential of alopecia areata. And this is telogen effluvium this time. Okay, so notice that there's a decrease in the number of follicles, but it's not one, it's not zero. I mean, they're basically miniaturized follicles here, but they're still present. So this person is going to have some hair in his or her scalp. It's not going to be totally just white and glistening and nothing's there like you see with AA when you get a really fully developed lesion. So you get a decrease in number of follicles and you get the miniaturized follicles, but it's not complete absence of them, and you don't get any inflammation around the follicular elements. So that's telogen effluvium in this case, and it's a non-inflammatory alopecia. Okay. So the next one, we've got what looks like an enucleation or an incision biopsy. So we've got just deep to the skin. So probably clinically was thought to be a cyst, maybe a lipoma. And we all know that when you get something that's kind of enucleated, it kind of comes out with the shells out. That's a sign of malignity. So again, when you see that at low magnification, this is probably benign. And it's most likely going to be neoplasm when it does that. Inflammatory lesions, they don't really enucleate because the inflammation sort of intercalates between the collagen bundles. So you're really not going to get that. So we're going to higher magnification, start looking at the individual cells, and you can see that they're pale, but they have something in their cytoplasm. They've got all these little small vacuoles in them. They've got this central nucleus in there. They've got these little sort of gossamer strands radiating from it, but the individual nuclei, some of them are sort of a little bit stellate, but most of them are just kind of round like this. And let's see if we can look around and see if there's anything else that might help us with the diagnosis. So this is something you sort of have to know, if you will, understand and see this, know about it, and be able to recognize it. This cell right here might give you a little bit more of a clue as to what we're dealing with, because these are little small lipid vacuoles. So this would be probably a lipocyte here, and these are cells of brown fat. So these are cells that we see in infants. This is a hybridoma, and as you all know, basically when you get kids that are born and they have brown fat, that fat is used to help them maintain their body temperature, and it's very, very highly metabolically active. The individual lipid droplets are broken down much more quickly because they have all these mitochondria in there. So a kid with that's born as brown fat, they can really thermoregulate better because they have this. Adults really don't have much brown fat in them at all, but occasionally you get a neoplasm with some residual brown fat cells, and this is what it looks like. So this is a hybridoma. I remember they had this on my board examination many, many years ago, before any of you guys were even conceived of. And this was the first slide we had. So they actually ask this on the board. So if they ask it once, they can ask it again. So you can easily have this at some point on the board examination. So make sure you recognize that this is brown fat and understand that this is what it looks like, and that basically these are comprised, the things that you're looking in here that have all these little sort of granular things, those are thought to be related to mitochondria. So it's interesting. Now, there is a differential diagnosis of this, and show the next slide in comparison. Okay, so this is also something that gives you cells that kind of have material inside their cytoplasm. So here, notice that these cells have kind of a granular cytoplasm. These are, in this specimen, they're almost kind of basophilic, but sometimes they can actually be slightly eosinophilic. And let's see if I can show the other side of it, maybe over here too. This is a different entity, but notice that the cells have a granular cytoplasm. So the hybridoma had sort of these little vacuoles with little small specks in them, if you will, in a central nucleus. And in some cases, even saw little gossamer strands sort of radiating from the central nucleus. Here we don't have that. We just have granules in the cytoplasm. So this is a granular cell tumor. And this is a different neoplasm. This is not a neoplasm of subcutaneous fat. This is a neoplasm that is in the family of neural neoplasms. And these are thought to be Schwannian in nature. And basically what happens here is that the lysosomes myelin, basically, the breakdown products of myelin and lysosomes don't break it all down, and they start accumulating the cells, and they sort of get chock full, stuffed, if you will, with these small little PAS positive and S100 protein positive staining areas, the great little lysosomes within the cytoplasm of these Schwann cells. So this is a granular cell tumor. So that's looks different than a hybridoma, but the cells can be somewhat, you got stuff inside the cytoplasm. Just make sure you can understand the difference, because they might have a multiple choice question, and they might show you hybridoma and put on their granular cell tumor as a choice. And if you sort of say, there's something in the cytoplasm, looks kind of granular, maybe it is that. Just remember there's no vacuoles in this. You don't get those little sort of nuclei that are centrally located with a small granular, the small stellate, sort of gossamer strands of the nucleoplasm radiating from those. And you don't ever get any little fat vacuoles of the cells in a granular cell tumor. And this will be S100 protein positive and PAS positive. The other thing about granular cell tumor is they often get pseudocarcinomatous hyperplasia overlying it. So if they show this to you, you'll often see that, and these often occur on the tongue. So you'll see areas of skeletal muscle in the biopsy very frequently as well. And they actually also often occur in dark-skinned patients, African Americans, fairly commonly seen there. The only thing I would mention about possibly the differential diagnosis of hybridoma, I'll go back to it, is possibly a sebaceous lesion. Okay, because if you just look at say this cell alone right here in a vacuum, you might say, wow, that looks a lot like a sebaceous cell. It's got lipid in the cytoplasm. It's got that kind of stellate nucleus. It's got the little gossamer strands of nucleoplasm that you just mentioned a second ago. But notice how it doesn't have anything else that kind of goes along with it. First of all, it's pretty large. It's got a lot of vacuoles in it, and it doesn't have any of the germinative basaloid cells that you almost always see, at least in some areas of a sebaceous lesion, and it's not really forming any sebaceous lobules. So that would be something else that they might put on there to try to trip you up, is they might put something like a, say, sebaceous adenoma or sebaceous sebaceoma, something like that on the differential diagnosis. But don't fall down that pitfall, because it doesn't really look anything like this. It doesn't have any of the basaloid cells when you look at a hybridoma. Okay, the next one we have here is a punch biopsy. We can tell right off the bat that it's an inflammatory process, and it's superficial and maybe mid perivascular infiltrate. We can't really see a lot about the cells, but we can tell at low magnification that it seems to be involving the interface. So you can see that this isn't a nice smooth transition between the epidermis and the dermis here. It's obscured. So we see that at low magnification. We also can tell that the cornified layer is abnormal. So it's an interface dermatitis with some superficial and mid perivascular infiltrate. They don't look like they're all jet black and dark, so the chances are they're probably not all going to be lymphocytes here. They may be something else. But when we start thinking of interface dermatitis, again, you should have a relatively limited differential diagnosis. So start asking yourself, okay, well, if it's an interface dermatitis and it looks like it's got a normal basket weave cornified layer and it's got mostly vacuolar alteration, you should be thinking about the erythema multiforme, Stevens-Johnson, TEN family of diseases. It's got some smudging and thickening of the basal membrane zone with a lymphocytic infiltrate, perhaps either superficial or superficial deep in the dermis. But then you start thinking about the connective tissue diseases like lupus erythematosus, dermatomyositis, those sort of things. If it's got some eosinophils in there, you might think more about a drug eruption. And here we do see that there's a fair bit of cornified layer abnormality, and hopefully you can see that it's got crust in it. So again, scale crust is parakeratosis plus neutrophils. Crust is just basically neutrophils, either with serum or with red cells, if it's a hemorrhagic crust versus a serous crust. So we got an interface dermatitis with a lot of crusting on the surface. The first thing that you should think about immediately is the possibility of the pityriasis lichenoides group of diseases, because they very commonly will give you that kind of cornified layer change. And notice that it's a broad zone of this parakeratosis containing neutrophils over a broad front. It's not mounds of parakeratosis with neutrophils at the summits of the mounds like we see with psoriasis. This is a broad zone. And also notice that there are dyskeratotic keratinocytes here, very common. There's epidermotropism, the cells are crashing into the basement membrane zone, crashing into the epidermis, and then you've got all of these neutrophils in the cornified layer. This has got more than we often see. Sometimes you can actually see collections of polys like we see here, but here we don't really, we've got that. That's not often, you don't see that all the time, but if you do see it, it's usually a pretty florid lesion of pityriasis lichenoides when we see it in this stage. So we also see a couple of other findings here, extravasated erythrocytes, nice example of the dyskeratotic keratinocytes, and then the infiltrate again consisting of lymphocytes and perhaps a few histiocytes here. And you'll also see some neutrophils in the infiltrate, but you do see neutrophils within the epidermis very commonly in pityriasis lichenoides. Now this would probably be a relatively acute lesion. Unfortunately, the way pityriasis lichenoides is named, it's named with, acute and chronic, but you can get people that have pityriasis lichenoides chronica for, 25, 30 years, and they can develop periodic recurrences and remissions of their condition and get acute lesions that develop in the setting of longstanding eruptions. So this could come from somebody that's had the disease for a long time, but the lesion itself looks pretty acute. If you do see, and then you see some people that have fairly acute lesions and you biopsy them and they really don't have much cornified layer change or neutrophils, they just have some focal interface change with some dyskeratosis and extravasate the red cells. You say, well, gosh, that looks more like a chronic lesion, even though the patient may have had it for maybe only a few weeks or months. So the disease itself is not named well because just you can get acute lesions in chronic patients and vice versa. So just remember that as well. Some forms, the so-called classic Muckahabermann form, it's usually a pretty dense, superficial and deep infiltrate that's wedge-shaped with lots of inflammation. And that's often seen in children. And that can be a really aggressive form of the condition. They can actually get sick, they can get febrile, they end up getting in the hospital, you have to give them methotrexate. There's been some cases of fatalities with acute, really bad Muckahabermann disease. So this wouldn't be obviously that severe, but it would be in that category. The other thing that you have to think about in the differential diagnosis of this is syphilis. And syphilis can do just about anything. So I've seen cases of syphilis look exactly like this almost. Usually they almost always have some plasma cells, more histiocytes, and also occasionally you'll see some cases of unusual lichen planus or lichenoid drug ruptures that can simulate this. So that's a nice example of pityriasis lichenoides. And the only other thing that can simulate it also is some forms of lymphomatoid papulosis can simulate it. Here's an example of another interface dermatitis. And notice here, mentioned earlier that if you get an interface dermatitis with epidermal necrosis in the basket weave cornified layer, that ought to make you think about the erythema multiforme and that group of diseases. And this is an example of erythema multiforme. So notice you've got a lymphocytic infiltrate, there's vacuolar alteration here, and there's these dyskeratotic keratinocytes at the basal cell layer and above it. And notice the basket weave cornified layer. So this wouldn't even be a scaly lesion clinically. There'd be no crust here, no scale. The epidermis would almost look normal. It would just be kind of red and maybe dusky. This could have come from an iris or target lesion. And if you leave this alone for a few more days, the epidermal necrosis probably would spread throughout the epidermis and then it would slough off and then it can kind of get crusty. But you'll see the basket weave cornified layer. And that's a sign that this happened very, very quickly, very acute, and didn't even have a chance to form any parakeratosis or anything like that here. So you really shouldn't have a lot of difficulty distinguishing between this condition and the pityriasis lichenoides conditions. So just remember that. It's a nice example of an interface dermatitis. This is another arrow over here which shows the nice vacuolar alteration before we have a lot of dyskeratosis. A few cells here, but not so many. And then the other thing that can look like this is a fixed drug eruption. That usually gives you a superficial and deep infiltrate with melanophages that are deep in the dermis because it occurs to the site over and over again. And then they also get eosinophils commonly in a fixed drug eruption. Okay. So shave biopsy here. And it's a dome-shaped papule. It's a neoplasm. So, it's got this reticulated epidermal hyperplasia, but it seems like something's going on in the dermis here that's not a totally normal pink hyalinized type collagen that we normally see in the papillary and reticular dermis here. So it's a papule. So, maybe there's some kind of abnormality going on down here, that it might be some sort of a connective tissue related process. And as you go to higher magnification, you start seeing these cells that are very dark and pleomorphic, and there's some edema between the individual fibroblasts here. So there's some, a little bit of mucin and some edema, and these collagen bundles down here are a little bit sort of thickened and slightly irregular. But the main changes are these really bizarre, irregular cells here. And these are fibroblasts, and they're what we call pleomorphic fibroblasts. You don't really see any mitoses or any striking atypicality. And so this is a dome-shaped papule that contained these bizarre fibroblasts in here. So this is an example of a pleomorphic fibroma. And pleomorphic fibroma, these pleomorphic fibroblasts, they can be seen in several different entities. They can be seen in this entity, but they can also be seen in certain things like in lipomas, pleomorphic lipoma. Occasionally we'll see them in leiomyomas. And then we can see these, usually if they're in things like an atypical fibroxanthoma or something like that, or in a melanoma, they're usually far more atypical with mitoses and whatnot. But if they just have these sort of hyperchromatic nuclei, and they kind of look almost like these little flowers, if you will, that are hyperchromatic, and it's a dome-shaped papule, that's pretty classic for a pleomorphic fibroma. And it's not anything to worry about. It's not cancer. It doesn't need to be excised, doesn't need to be worked up. They usually come in as like a roulette nevus or roulette basal cell, something along those lines. So it's just kind of one of these interesting kind of quote gee whiz in quote sort of histology thing that you just need to know about, and don't overdiagnose these as cancer. Again, remember using all of the criteria to make diagnoses: the small size, the circumscription, all those various things. Those are just as important as the cytology. And in this case, it really wasn't really anything to be concerned about, but just be able to recognize that these are these pleomorphic fibroblasts that we see in this lesion and in a few other entities. Kind of a little bit, they might show you this on the boards. They're not going to get into and they might show you a pleomorphic lipoma possibly. So just recognize the concept of those pleomorphic cells that can be seen in benign lesions. But that sort of gets a little bit obscure, and it kind of gets more into the realm of maybe board dermatopathology board. So I doubt you're going to see that on the exam. If you do, it'll be something that's going to be fairly simple. This is another entity. This one you very well could see this on the board examination. Dome-shaped papule. It's got, and notice here we've got this thick collagen that's almost a little bit sclerotic. We've got a lot of blood vessels here, and we've got fibroblasts here as well. They're maybe slightly pleomorphic, but certainly not like we just saw in the last case. So this is an angiofibroma. It's or fibrous papule if it's seen on the nose. Probably the most important thing here would be if they show you this and they ask you something about tuberous sclerosis. So this would, if you biopsy a patient got tuberous sclerosis, that's got the so-called adenoma sebaceum, the multiple lesions on the face, even the lesions around the finger, the Kiernan tumors there. If you biopsy those, they show features of angiofibroma. So they very well could show you this and expect you to get the diagnosis pretty quickly, and then ask you a second order question about this patient might also have these other stigmata. And then they might ask you about a shagreen patch or maybe crow's sign in the axilla, or something along those lines. So they make sure you understand and know the things that go along with tuberous sclerosis. Make sure you understand the genetics of tuberous sclerosis. They like to ask anything that has to do with genetics of a syndrome, and they can tie back to something in dermatopathology. So expect to get the answer of this pretty quickly, and then be able to sort of know the various things that are associated with it. So that would be totally fair game on the exam. Okay, the last one here. Let's go to this again. Okay, and once again, sometimes it's better to diagnose things at low magnification, and you can kind of see that they almost did a telescoping type biopsy here. They took a punch biopsy, and then they actually went to the bottom of this area and took another punch. They went all the way down almost to the fascia here. I think that probably is the fascia in this case. And so they're trying to find out what's going on really deep to the skin. And you can see that the epidermis is normal and there's really minimal inflammation. There's maybe something going on here around the subcutaneous fat. Look at this area, you can kind of see that again. And notice this inflammation is kind of situated at the junction between the collagen bundles and the fat. That's pretty characteristic of these conditions. And you can see that this is not normal. It's also squared off. So at low magnification, if the biopsy looks kind of like a square, you all know that that means that the collagen is thicker than normal. And it can be thick because it can either be sclerotic. It can be thick because there's maybe too much collagen. Let's say it might be like collagenoma or dermatofibroma, something along those lines. It can be thick because there may be something deposited there. What if there's a lot of mucin, or maybe there's some kind of neoplastic cells like breast cancer or something like that, that can give you a squared off biopsy. So a lot of things can do that. It's not just only sclerotic collagen, but in this case, at higher magnification, you can see that this collagen is sclerotic. There's a decrease in the number of fibroblasts. There's homogenization of these collagen bundles. And you see that there's actually a little lymphoplasmacytic aggregate of inflammation here, seen at the periphery of these thick sclerotic collagen areas, and the residual amount of fat that's being choked off. Here you see the adnexal structures, the sweat glands. They look like they're sitting right in the middle of the reticular dermis. Normally they should be the subcutaneous fat. So this fat has largely been replaced. And over here, you can actually see it goes into the fascia. This is beneath the dermis. So this is just beneath the entire skin. This is getting down to the fascia. So when you see that, there's really a couple of things that you should think about. One is obviously eosinophilic fasciitis, which gets into the fascia. And in order to diagnose of any form of fasciitis, you have to sample the fascia. But basically, if you look at that, it looks like morphea or scleroderma or any of the progressive systemic sclerosis diseases, that they all look the same as far as the sclerotic collagen goes. It just happens to be situated far deeper than we see in classic morphea. So, if you see eosinophils in the biopsy, that's helpful. But actually, interestingly enough, in some of these patients, they don't really have to have eosinophils in the tissue. It can be circulating eosinophils. So the classic story is the person that goes and runs a triathlon and does all that kind of stuff, and then they come back and their muscles start aching. Maybe they get rhabdomyolysis, and then they get their skin gets thickened, and they get eosinophilic fasciitis associated with it. So it's kind of an acute something related to trauma. That's the classic thing. And then occasionally it can occur sort of in an idiopathic fashion. In this case, this patient just simply happened to have a few localized areas, but it just went really deep. So this was an example of morphea profunda. So this person didn't actually have the fasciitis that was associated with eosinophilia. They just had localized areas of morphea that really went deep. So morphea also can get all the way down into the fascia sometimes too. So these are, again, just the concept of the sclerotic disorder. So if you biopsy one of these and submit it to us as rule out morphea, we're going to probably sign it out as morphea. And if it goes deep, we might say consistent with morphea profunda. If you send it in and say this gives a classic story of eosinophilic fasciitis, it looks like this, then you're going to get that diagnosis back, because they pretty much all give you the same kind of reaction pattern of the sclerotic collagen that we see in the dermis. Now, I don't know why plasma cells go along with sclerotic collagen, but they do. So anytime you get these sclerosing disorders, they almost always, if there's any inflammation in there, we're going to have some lymphocytes and plasma cells, and maybe if it's an early lesion, some eosinophils in there as well. So just remember that. And again, maybe at some point in the future, that may be some kind of therapeutic intervention, but you almost always see plasma cells when you get these sclerosing disorders. So I would recommend knowing those. I would also know some of the other conditions that you can get sclerosis in that are not really classically related to morphea. The sclerodermiform change that you see with some cases of chronic PCT, graft versus host disease, toxic oil, L-tryptophan deficiency, and then the differential diagnosis of nephrogenic systemic fibrosis. Even though we don't see that many cases anymore of that today, because gadolinium isn't really being used as much as it used to be. That's not really a sclerotic disorder, it's a fibrotic disorder, but it also gives you very thick, deep involvement that goes all the way down to the fascia and even down to the periosteum and bone and things of that nature. So the last one, sort of in contrast, I wanted to show you, is another biopsy. Notice this is also squared off, okay? So again, just because it's squared off, don't instantly think of morphia. Remember, we mentioned some other things there too that can give you, this thick, firm collagen. So when you biopsy it, it gives you a square biopsy. So just don't instantly go to morphia. Here we've got mostly involvement of the subcutaneous fat here. So this fat is inflamed. It's a lobular, mostly paniculitis. We've talked a little bit about paniculitis in some of these conferences before. So again, if it's mostly lobular, then look at the type of inflammation. Here you can see that it's mostly lymphocytes and plasma cells. Notice that these lipocytes here have got this pink hyaline mummification of the lipocytes. And so this is a classic example of lupus erythematosus profundus. And that also will give you a very woody, indurated clinical feel with these large, deep gullies where the skin has just basically been, it's lost. Most of the substance of the skin is being replaced by this inflammation down here, and the fat's gradually being degenerated, and it gets very thick, and you get these depressions in the skin. You'll often see some overlying change of LE above lupus profundus, but in this case, we don't have that. We just have only involvement in the subcutaneous fat. And notice once again, this infiltrate of these lymphocytes and plasma cells that are kind of going along with this sort of degenerated fat that's turning into this mummified, thick, sclerotic collagen over here. So this is LE profundus, a nice example of that. And LE profundus patients, about 65% of them will be associated with some form of systemic lupus erythematosus. So it's not usually purely cutaneous. Sometimes you get overlying DLE changes, but sometimes you will not get that. So anyway, that's 5 interesting cases for you today with some examples of contrast. Hopefully it was good for you. Let's see, we got a couple of questions in the chat. Let's see if I can read those. We've got a couple of minutes. Let's see, is this one associated with Cowden's? No, angiofibroma is not associated with Cowden's. Those generally are things like tricholipomas, okay, and sclerotic fibromas. Again, those are associated with Cowden's. And fibrofolliculoma is associated with Birt-Hogg-Dubé disease. So don't get those confused. Make sure you know all of those various entities and which ones are associated with what things. So fibrous papules, multiple angiofibromas, tuberous sclerosis, fibrofolliculomas, trichodiscomas, perifollicular fibromas. Those are Birt-Hogg-Dubé, and in Cowden's you get tricholipomas, and sclerotic fibromas. Okay, we got a trick to things, maybe septal paniculitis. Yeah, if you see that much involvement of the fat like this, that's not septal, man. That's like wiping out most of the lobules here. A lot of times what you'll see, like in erythema nodosum, you'll see the septal paniculitis with just some periseptal inflammation, but you'll see thickening of the septa and then periseptal granulomatous inflammation. If you see something like this, it's just kind of extensively diffuse involvement of fat, that's lobular. So that's like wiping out the lobules. If you get septal that's got some periseptal inflammation, that's still considered septal mostly. And then if you get something like erythema nodosum, we get suppuration diffusely in the fat with larger vessel vasculitis. Obviously, then you've got that diagnosis that you can render with certainty. Let's see, got one other question here. The prior slide. Were you talking about the morphia case, the morphia profunda case? Yeah, okay. Well, that's interesting because morphia can actually give you a septal, a septal paniculitis in morphia. You get that. If you get that early on, and I'll go back to this, and it's not so obvious here because you just got such massive diffuse thickening down here. But if you get early morphia profunda, you can actually get the thickening of the septa of the subcutaneous fat. And if you look at those, you'll actually see that there's sclerosis there. If you get it super early, it's edematous. And that's what you see in the so-called puffy phase of scleroderma. So you ever see a patient's got, maybe their hands get kind of puffy and they start complaining they can't close their hands. It's usually a relatively young individual, often a woman. And if you do a deep biopsy of that, you'll see the septa of the fat are thickened and they'll be edematous. They'll almost be sort of like this kind of change here. That looks sort of, there's still some edema here because this is still in the relatively early stage in the very bottom part of this fascia. So it kind of looks like that, but it's in the septa. And then it starts turning into the sclerotic collagen like you have here. It's markedly thick and ropey, homogenized collagen with loss of fibroblasts. So that's what you see in so-called morphia profunda in an early stage. So that's early on, it's septal, and then later on, it just kind of starts replacing everything. So, but it is a type of septal paniculitis. You're right about that. But if you get it when it's here, it's kind of gone past that stage. Okay. Any other questions? Sorry about the audio problem, but maybe it's fun not to get called on. Your blood pressure stayed normal today. No tachycardia. So maybe next month we'll be able to actually hear you, and I'll be able to go back to asking your questions again. Yeah, I think you do learn more if you do it that way, even though it's not quite as much fun. So thanks for joining in, and have a good week.